Hello friends, today we are going to discuss the question which was asked in DRNB Critical Care Exam 2020. The question was differential diagnosis and management of acute flaccid paralysis. So acute flaccid paralysis, it is the syndrome characterized by the rapidly evolving diffuse muscle weakness, muscular hypotonia, deep and abolished hypoactive reflexes. It is a sudden disease that develops in hours to weeks, and acute term refers to neurological disability in this range. The time of acute flaccid paralysis evolution varies and depends on the etiology. The incidence of acute flaccid paralysis is used by the WHO as an indicator of polio eradication. So, the etiology of acute flaccid paralysis. If it is caused because of the spinal cord injury, then it is divided into infectious causes, inflammatory causes, compressive causes, and vascular causes. Infectious causes include human deficiency virus, syphilis, tuberculosis, bacterial, and the viral infection. Inflammatory causes include transverse myelitis and multiple sclerosis. Compressive etiology include tumor, hernia, disc protrusion, and abscesses. Vascular pathology include ischemia, syringomyelia, epidural, subdural, spinal cord hemorrhage. Then previous spinal cord injuries include poliovirus infection, Coxsackie infection, West Nile virus infection. Then roots and the peripheral nerve disorder include GBS, diphtheria syndrome, paralytic seafood poisoning, tick bite paralysis, porphyria, heavy metal poisoning, critical disease polyneuropathy, acute alcoholic polyneuropathy, acute toxic and needy polyneuropathy. Neuromuscular junction disorder include myasthenia gravis, Eaton-Lambert myasthenic syndrome, botulism, aminoglycoside toxicity. Muscle disorder include necrotizing myopathies, metabolic myopathies, acute alcoholic myopathy, muscular dystrophy, and periodic paralysis. Myelopathies are disorders that affect the spinal cord or part of it. The clinical picture varies with the etiology. Loss of the muscle strength associated with the bowel dysfunction, urinary and bladder dysfunction, and defined sensory levels suggest the myelopathy. In acute phase, there may be hypotonia, reduced reflex. In later stage, the reverse occurs, reflexes increase and spasticity. Progressive weakness in the legs and the arm preceded or accompanied by the pain in the spine, lower limb may suggest compressive myelopathy. Lesions limited to the anterior horn of the spinal cord are not accompanied by changes in the sensitivity but may have muscle flaccidity and fasciculation. Regarding the diagnosis, MRI is the useful in cases of acute myelopathy since it demonstrates the site of the lesion. Then acute polyneuropathy. Peripheral nerve damage causes the distal muscle weakness, sensory changes limited to the nerve and the root territory. Toxic neuropathies, it results from the exposure to the drugs, industrial agent, and the environmental toxin. Although rare, it is essential in context of unknown and suspected toxic exposure, especially in the workplace due to heavy metal poisoning, and is reversible when toxic agent is identified or removed. Arsenic poisoning can generate polyneuropathy that mimic GBS in addition to the systemic effect that facilitate diagnosis. Then tick bite paralysis. It is caused by the neurotoxin secreted by the adult female ticks in North America and the east coast of Australia. The disease is common in children under 8 years old. Paralysis affects the isolated cranial nerve and may progress to quadriplegia, paralysis of the respiratory muscle. Symptoms are influenza-like irritability, drowsiness, anorexia, pain, and paresthesia that appear within the 36 hours. After 4 to 7 days of the bite, neurological symptom, ataxia, weakness, and muscle paralysis appear. When tick is removed, symptom disappears spontaneously. Metabolic neuropathies. Diabetes is most common cause of duration-dependent symmetric polyneuropathy in developed world. Polyneuropathy is related to the disease duration and the mean glycated hemoglobin and early age. In acute autosomal dominant porphyria, the heme synthesis is abnormal. Heterozygous patient experience dangerous, life-threatening neurovascular attack following precipitating factor. So symptoms are severe abdominal pain, vomiting, constipation, bloating, sometimes followed by confusional state in the psychiatric disorder. Tachycardia and hypertension may occur in addition to seizure by hyponatremia. Progressive muscle weakness accompanied by myalgia may be asymmetric starting in the upper. The diagnosis is confirmed by the presence of heme metabolites in the urine. Then diphtheria neuropathy. Historically, diphtheria has been significant cause of morbidity and mortality in pre-vaccination area. Currently, with the reduced cases due to DTP vaccine. The disease occurs from a toxigenic strain of Corynebacterium diphtheria, whose free toxin lead to the formation of pseudomembrane in pharynx, so called as pharyngeal diphtheria. After 2 to 6 days, there may be palate paralysis, nasal voice, numbness of the tongue and face, dysphonia associated with other affected nerves. Following this, sensory motor polyneuropathy and proximal quadriparesis associated with paresthesia appear in about 60 to 90% of patients. Electroneurography demonstrates demyelinating process. Then neuromuscular disorder junction. It is the disorder of myoneural plate that presents the acute muscle weakness and absence of sensory sign or symptom. So the myasthenia gravis will come into this. It is one of the most common pathology results from the immune-mediated aggression of acetylcholine receptor on motor plate membrane, and it alters the neuromuscular transmission. It occurs at any age and it is common in the female. The onset may be acute, affecting striated muscles of the lower and the upper limb and to related to cranial nerve, having a favorite target for extraocular muscle. Skeletal muscle weakness is fatiguing and fluctuating throughout the day. The trigger factors of acute phase are fever, infection, intense emotion, excessive exercise, extreme heat, hormonal changes, pregnancy or menstruation with spontaneous remission. The diagnosis is made by the clinical history, positive endophonium test, electroneuromyography with response to decreased muscle action potential. The presence of acetylcholine anti-receptor and the striated anti-muscle antibodies are used as diagnostic method. Then Eaton-Lambert myasthenic syndrome. It is a disorder due to immune-mediated aggression of the presynaptic membrane, uh, calcium channel in myoneural plate. Up to 60% of the cases stimulate paraneoplastic manifestation associated with small cell lung cancer, while remaining cases are related to underlying autoimmune disease. It resembles myasthenia gravis, evolved with the progressive proximal muscle weakness, fatigue, flexia, then the autonomic symptom, so that specific neuromyographic pattern and the autoantibody search may help in differential diagnosis. Aminoglycoside, tetracycline, penicillamine, and diphenylhydantoin can cause the presynaptic neuromuscular blockage, triggering signs and symptoms similar to myasthenia. Then next is botulism. It is caused by toxin from Clostridium botulinum and other neurotoxin Clostridia. It is a rare disease but can kill. Food botulism due to poisoning is the most common worldwide, rarely occurring after injury, injecting drug use, iatrogenic after toxin injection, or of unknown etiology. After about 12 to 48 hours of contaminated food intake, gastrointestinal symptoms are preceded and soon after neurological sign with symmetrical impairment of cranial nerve and autonomic disturbance, which develop into balance and descending flaccid paralysis of voluntary muscle, may be compromise the brain. Diagnosis is made by measuring serum toxin. Electroneuromyography reveals the increased pattern of myoneural plaque dysfunction. Then muscle disorder, which is caused by either hypo or hyperkalemia. Potassium level above 7 or below 3 is associated with confusion, affective disorder, as well as muscle necrosis and rhabdomyolysis if potassium is less than 2.5. In cases of hyperkalemia, paresthesias and fasciculation are observed in muscles of upper and lower limb, generally sparing trunk, head, and respiratory tract muscle. Besides, the patient have weakness associated with ascending paralysis and flaccid quadriplegia. Serum potassium should be corrected and the underlying cause of change must be investigated and treated. Other electrolyte disorder like hypophosphatemia and hypermagnesemia may lead to acute flaccid paralysis. Then channelopathy, rare neuromuscular disorder of genetic etiology related to the mutation in sodium, calcium, potassium channel gene in skeletal muscle. Formerly known as familial periodic paralysis, the hypokalemic form is the most frequent and is associated with changes in calcium channel, muscle weakness after exercise, or ingestion of large amount of carbohydrate. Within channelopathies, we have beside hypokalemic paralysis, hyperkalemic paralysis, Anderson-Towel syndrome. For example, it resolves spontaneously within hours to days. Periodic paralysis are rare neuromuscular disorder which is caused by mutation in skeletal muscle, sodium, calcium, and potassium channel gene. Then myopathies. These are the muscle disorder of any etiology that can lead to acute muscle paralysis. The main one are inflammatory and metabolic. Inflammatory myopathies, polymyositis and dermatomyositis. These are the rare autoimmune diseases that affect the female of 20 to 40 years. They have second peak after 65 years of age. It may be associated with other diseases like carcinoma, lymphoma, and autoimmune disease. The onset of symptom is subacute, proximal weakness, and it affects the cranial nerve. The diagnosis is made by the presence of two of the following characteristics, being definitive if three are present. Clinical manifestation, creatinine kinase elevation, electrophysiological examination, and muscle biopsy. The treatment is based on corticosteroid. Inflammatory myopathies also include infectious myopathies, which may be caused by viruses like influenza A, B, HIV, Epstein-Barr herpes virus, then bacteria like Staphylococcus aureus, Clostridium perfringens, fungus like Candida albicans, and parasites like Toxoplasmosis, trichinosis, and cysticercosis. Then metabolic myopathies. Thyroid dysfunction can lead to myopathy in 30% to 80% of hypothyroid case with proximal weakness, muscle stiffness, cramps, rhabdomyolysis associated with muscle weakness, uh, myalgia, and elevated creatine kinase and myoglobinuria. In hyperparathyroidism, there may be generalized muscle weakness, bulbar, myasthenia gravis, periodic toxic paralysis, and thyroid ophthalmopathy. Acute manifestation of muscle weakness is most commonly seen in thyroid storm, where symptoms are critical. There is also toxic myopathy, which can be caused by affecting myoneural junction or the muscle itself. Some substance related to this type of myopathies are statin, barbiturate, chlorpromazine, lithium, amphetamine, salicylate, corticosteroid, and zidovudine. Alcohol can cause myopathy due to toxic effect of its consumption or associated malnutrition, either acutely or chronically. The acute form affects the 5% of alcoholics with muscle weakness, pain, and elevated CPK and myoglobinuria and possible rhabdomyolysis. Genetic myopathies are clinically heterogeneous and progressive muscle disorder with autosomal changes, recessive or dominant inheritance. Despite the different etiology and clinical presentation, all are characterized by the muscular pathology. Examples are myotonic dystrophy, X-linked dystrophy, mitochondrial myopathies that may appear in the emergency department due to clinical deterioration, generalized muscle weakness, and respiratory failure. Then critical patient muscle weakness. The critically ill patient has general condition and is usually admitted to the ICU. High-dose intravenous corticosteroid, neuromuscular blockers, sepsis, and multiple organ failure are thought to play the essential role in the development of acute flaccid paralysis in this patient, but pathophysiology is not well understood. They may have diffuse polyneuropathy, dysfunction of myoneural junction or muscle. Throughout the pathophysiological process, we can observe long-term sustained muscle loss and dysfunction, which causes the physical disability. To differentiate from the GBS, subsidiary tests are required, such as CSF connection. Thank you.